Just for those who've just joined us, we're just going to start in a minute or so, just waiting for a few more people to join. Good afternoon, everyone. On behalf of the National Children's Bureau and the Young People's Health Partnership, who are both part of the Health and Care Voluntary Sector Strategic Partners programme, I would really like to welcome you to the webinar today, which is focusing on child and adolescent mental health services transformation, 1 year on from Future in Mind. Sorry. My name is Emma Rigby. I'm the Chief Executive of the Association for Young People's Health, and I'm going to be doing my best to guide you through. This webinar really follows on from a voluntary sector seminar that we held in July of 2015, and given that so much has happened in child and adolescent mental health, this is a really great opportunity to catch up with where we are now and talk about some of the issues facing the voluntary sector and beyond. So before we get started, I just want to go over a few items so you know how to participate in the webinar today. You have joined the presentation listening on your computer's speaker system by default, but if you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed for you. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the attendee control panel on the screen, and I would really encourage you to send in your questions at any time during the presentation, and I'll be collecting these and making sure that we address them during the question and answer session at the end of today's presentation. When you do put your questions in, just if you can tell us what your organisation and where you're based, that would be really helpful because it really helps us to know who's on the call. We're expecting about 40 attendees and a really great geographical range of people and also from different organisations. So you're very welcome. So without any further ado, I'm really delighted to introduce Claire Bethel, who is Deputy Director of the Children and Young People's Mental Health and Wellbeing at the Department of Health, and Claire, who has been leading on a lot of this transformation work, is going to provide us with an update on the latest developments in the process of transforming child and adolescent mental health services. And this is really about helping local organisations, practitioners, the voluntary sector understand and engage with what's happening to ensure that we're leading to the best possible outcomes for children and young people. So sit back and enjoy Claire's presentation and make sure you give your questions during it so that we can collect them for the end. Thank you.
Very much indeed, Emma, for that kind introduction. My name is Claire Bethel and I've worked in the Department of Health for some time and been involved with the whole of the Future in Mind process. So I'm going to give you a little bit of the context this afternoon, but then tell you what we've been doing in the last year and so on. So although I'm from the Department of Health, we're working very closely with other organisations, particularly DFE, Department for Education. This is a cross-government programme, but also with our colleagues in the arm's length bodies, NHS England, Public Health England, Health Education England in particular. So this isn't just a Department of Health programme, and a lot of it is led by those other organisations. So first of all, just a little bit by way of context. Sorry, I'm trying to move the slide on. Sorry. Sorry, the slide weren't working perfectly now. Just a little bit of a hiatus. Thank you very much. Sorry about that. Okay, so just a little bit about morbidity and prevalence of mental health problems. So mental health problems are one of the most significant health issues facing children and young people, and that slide on the left actually shows in the orange bit the proportion of illnesses that affect people of all ages. So you'll see that the orange funny shape there is actually the burden of disease of mental health problems in children and young people, and it is fairly significant. It's actually an Australian slide, but we have no doubt that there's a similar pattern of morbidity in this country as well. And I mean, one of the reasons why this is so important is because 50% of lifetime mental illness, apart from dementia of course, starts by the age of 14, and 75% of lifetime mental illness starts by the mid-20s. So obviously, the more that we can do to actually address mental health problems in that age group, the better. So there's a very strong economic case for intervening early, and we know that unfortunately that doesn't always happen. So one of the things that we did when we were working on Future in Mind was to produce an economic case, which is actually summarised in the document. And we know that only about 1 in 4 children and young people with a diagnosable mental health problem actually receives support, which is clearly not ideal, because we know that intervening early makes a very, very real difference. So there's very strong evidence for interventions that make a difference and are cost effective. So just looking at children with conduct disorders as an example, they can be up to 10 times more costly to the public sector by the age of 28. They have a very, very heavy cost that's spread across lots of different systems, such as education, the criminal justice system, and so on. And one severe behavioural problem can cost up to £250,000 per child, so it's incredibly important. And group cognitive behavioural therapy is known to be very effective and cost effective, so just providing those early interventions pays dividends into the public purse, and enables somebody perhaps to go on to be to have far fewer problems, much better outcomes than they would without treatment. So I think there is an irrefutable case that can be made as far as the economic cost is concerned of mental health. So what are the challenges? Well, we identified some of these in Future in Mind. As I say, very high prevalence of mental health problems, and I'll say a little bit more about prevalence later on, because you'll know that we don't have very good data on prevalence at the moment. It's not very up to date. But we do know that there's been an increase in demand on services, 11% in the last year, and that doesn't necessarily reflect an increase in prevalence, because it could actually be just wider recognition, the fact that it has such a high profile at the moment, people are more likely to refer and so on. But the increase in referrals, I mean, although it's 11% in the past year, it's actually significantly more than that according to the data that we have got in the last 2 or 3 years or so. Resources are obviously an issue, and it obviously isn't all about central government funding. There's a huge pressure on all public bodies, and we do feel that there is some correlation with pressure on local authorities' contributions to child and adolescent mental health, and I'll say a little bit about that later on in terms of what we found from the local transformation plans on as far as that's concerned. Complexity is obviously significant, and we know that complexity is thought to be increasing. So the children who are actually presenting to services are presenting with increasingly complex needs, and these may be children who would have been picked up much earlier, previously 10, 20 years or so ago, through earlier intervention, through youth services and so on. So at the moment there are a number of different agencies providing care and commissioning services, so that's another aspect of complexity, and one that we really would have liked to have tackled in the Future in Mind report and the work that we've done since, but it's actually quite difficult to do so because commissioning responsibility is spread between local authorities, schools, and in the NHS, NHS England, and clinical commissioning groups. So it isn't that easy to sort it out. Stigma, I'm going to come back and talk about stigma, but 45% of parents never talk about mental health to their children. And we know that children and young people with mental illness have considered suicide because they are so concerned about what their friends might say and so on. There is also a lack of data, and people often ask us, well, how come this situation has been allowed to carry on for so long, and I think the lack of data has been a really major issue. So we are doing a lot of work, and the new data set on child and adolescent mental health services is starting to flow this year. That has taken some time to get to this point, and it's going to take some time before that data is actually robust. So as I say, at the moment, only 1 in 4 children get the help that they need, and we know that there is very variable quality of care around the country. So the vision for change was set out in Future in Mind. We did a lot of work with children and young people directly. Through Young Minds, they did various surveys, and although the process was actually undertaken quite quickly based on the work of the task force, we did actually do a lot of work and get a lot of input and feedback from children, young people, and indeed families. So the aspirations are set out in the slide. Starting with improved crisis care, and there's a whole program of work in place to produce guidelines and care pathways and so on crisis care. What we don't want is children carrying on being admitted to police cells when they need an emergency admission, for example. So there's work going on to make sure that children get care in the right place at the right time, close to home. Improve transparency and accountability across the system, a much better offer for the most vulnerable children and young people. There were 4 task and finish group reports that you probably looked at that fed into Future in Mind. One of them was on vulnerable groups of children and young people, and the major problem that was identified in that was around access. Just picking out a couple more of these, professionals who work with children and young people trained in child development and mental health, and although it sometimes surprises people, even GPs don't actually have very good training on some of these issues, let alone teachers and so on. So what we really need to do through the workforce strategy is to have much better training that underpins undergraduate and postgraduate training for all of the staff who work with children and young people, so they understand what's normal in terms of child development and so on. Transition is a major problem, transition to adult mental health services, because adult mental health services are very frequently not there. So going on to the next slide, we are now 1 year on, just over 1 year on from publication, and I'm sure some of you will have been at the fantastic conference that we held with NHS England a couple of weeks ago, where we had a wonderful presentation from children and young people expressed through the dramatic arts. That was very good. So this is what the report looked like for those who haven't seen it. So it's fantastic to be able to reflect back on what's been achieved in the past year. I also wanted to mention the work of the Whole Life Task Force that was published in February this year. So that's the 5-year strategy produced by an independent mental health task force chaired by Paul Farmer of Mind. And that's looking, although that's looking at the whole of the task force, that does actually reinforce the commitment by public bodies, including NHS England, to delivering what's in Future in Mind. So that is our strategy for the next 5 years, so very important. We were very fortunate in securing extra funding under the coalition government, which this government has continued to commit to, and that includes £150 million tackling eating disorders over the next 5 years, and that will be through the development of community-based services so that children and young people don't need to be admitted to hospital so readily with eating disorders. It's a much better way of treating children, because we know that at the moment when they go into hospital with an eating disorder, they come out having done quite well, put on weight and so on, and then quite often unfortunately deteriorate. So what we're setting up is a system whereby they will be treated in the community alongside the family and so on, and it's a much better service. In March last year, we just soon before the election, just to chime with publication of the report, £1.25 billion was put in place to transform services over the next 5 years. So that includes £75 million for perinatal, but the rest is for children and young people's mental health. And then in November, there was an extra £600 million announced for mental health. So that's largely for adult funding, but there'll be some benefits for children and young people as well, and including those in transition. So just to show you a little bit about where the funding is going, we want as much as it as we possibly can to go out to local areas. And LTPs are local transformation plans. So every area was asked to produce a local transformation plan to set out how they were going to use the money, what they were going to do with it, what their plans were, what the particular issues were based on their local need, local problems and so on. And I think that's been hugely successful because every area did produce a local transformation plan to a very, very strict timetable, and there is a very strict assurance process in place to make sure that that money is spent on the things that they said they were going to spend that on. So that's been very, very important. But as I say, the vast majority of the money is going out through that route and will end up in CCGs. So that's important. We're also continuing to roll out children and young people's improving access to psychological therapists. So this is very different from the adult IAPT program, which some of you will be familiar with. And CYP IAPT is a complete transformation program in itself that's now been running for some 4 or 5 years, and we spent quite a lot of money on that already. And it covers 83% of the country so far, but actually will cover the rest of the country within a couple of years. So that will carry on, and that includes things like a commitment to evidence-based practice. The money actually pays for backfilling people so that they can go back to college and study how to deliver those evidence-based interventions and then roll those out in the organisations that they work in. It includes much clearer emphasis on routine outcome monitoring and so on for children and young people, so they are empowered to negotiate with the therapist at every session what they want to get out of it and whether that's been achieved. So a lot of that money is going into training additional therapists, both through NHS England and Health Education England. And obviously this program is only going to work and be successful if we do manage to recruit and retain those additional therapists. So that's really important. And by therapists, I'm talking quite broadly about psychotherapists, counsellors in schools, psychiatrists and so on, but also empowering and enabling people in universal services, school nurses, health visitors, GPs and so on, to treat and deal more proactively with children and young people. Vulnerable groups. In the report, we identified a number of vulnerable groups, but we didn't distinguish between them, but looked at them more generically because, as I say, the issues that we identified were fairly generic. The children with additional vulnerabilities, such as those with learning disabilities, asylum-seeking children, those who've been sexually abused and exploited, and so on, were found to have very poor access to services and treatment. We are piloting in schools having a single point of contact in the school, a little bit like a Senko, who actually relates to somebody in the local CAM service, and so there's a much better interaction between them. So teachers in schools told us through the consultations that they don't know what to do, and a child obviously is suffering with mental health problems. So the pilot, which is putting in place training and so on, will ensure that's a much more effective triage between the schools and the mental health services. We have a number of digital projects that we're investing in. We know that some children prefer to access services online, and there's nothing wrong with that. The evidence for it is fairly strong. It shouldn't be a replacement for online, for direct face-to-face treatment, but digital projects are very important. So if you look on NHS Choices, we now have a youth mental health hub, which is being very well used and so on. But we're also putting in place a kite mark system so that any apps that are arising and being developed in mental health will actually go through some sort of kite marking process to make sure that they're clinically effective. Tackling stigma, I'm going to come back to that in a minute. That's Suli Breaks, leading our campaign on children and young people's mental health stigma. And workforce innovation. As I say, this process and program is only going to be as innovative and successful as we are in developing the workforce, because that's what it's all about. So the transformation plans I mentioned, just to give you a little bit of an idea about the timing, guidance was issued in August. There were 2 pieces of guidance, one specifically on eating disorders and one on the whole of the local transformation process. So the plans need to include young people's views, they have to consider the contribution made by the voluntary and community sector, and also they had to consider the full spectrum from prevention through to intervention, and they had to be truly transformational and multi-agency. So those that were not thought to be transformational transformational were actually rejected. And sent back, and they had to be worked on further. But I have to say this is only the first step in the process, and it is an ongoing process. People will have the opportunity to build on those plans. They won't give them very long to do them. But all the plans were submitted on time, and there was a very rigorous assurance process put in place by NHS England, so all of those plans were assured, and then in December, January, the funding was actually released. We're now doing some analysis of those plans because there are an awful lot of them, and you can look up your local plan through that website. We're trying to make sure that they're all online at the local government association website. The funding has all been released for the current year and has been built into baseline funds for the rest of the 5-year period. As far as the NHS is concerned anyway, some of the money is going for Tier 4 services, that's inpatient services, so will be retained by NHS England, and a very, very small amount by the Department of Health for central programmes. And then in June, the NHS has been asked to produce sustainability and transformation plans. I think they've stolen our idea there. And that will cover everything, so everything from diabetes to A&E and so on, but that will make some reference to what's going on within mental health, including children's mental health, and they will need to align with the local transformation plans that have been produced already on children's mental health, and then local areas will actually have the chance to refresh those. So there's a lot of work going on to keep them up to date, to engage children and young people. There's been some fantastic and really inspiring examples of that, how people have worked with children and young people at local level to actually engage them in the process, which is fantastic. This rather scary slide is a summary of the local transformation plan, so I won't take you through every part of it because it's quite complicated, but some of it is quite useful. So for example, the bit in the middle at the bottom shows what the annual spend is. So you can see that 628 million is spent by CCGs and local authorities. That was in 2014-15. On top of the £250 million that was spent by NHS England, and that would be mainly on specialised services. So one of the differences between the way that the services worked previously and now is that NHS England commissions centrally all the inpatient services. It's also quite interesting to note at the bottom that 60% of funding comes from local authorities, 46% from CCGs and 38% from NHS England. The square in the middle shows you the approximate annual spend on services, so that is worth looking at. If England were 1,000 children, young people, in other words, a village of 1,000 children, young people, this gives you some idea of scale. So 24 children referred into community services on an annual basis, 18 referrals accepted into community services, so there's a bit of a disparity there, and that's been made quite a lot of in the Centre Forum report that was published this week, but there can be quite good reasons for that which are worth thinking about. £78 spent on community and inpatient services per child, and so on. So what have we been doing? Well, I mentioned the Stigma Campaign. It's the first ever anti-stigma campaign dedicated entirely to children and young people, part of the wider Time to Change programme run by Mind and Rethink Mental Illness, and as I say, fronted by Suli Breaks. We produced an advertisement that was publicised quite widely, that was online and so on, so do have a look at that. It was called No Judgment, and it's about the conversations between children and parents about mental health problems and how parents should be encouraged to talk to their children about these complex issues. And that came after research that showed 55% of parents don't talk about mental health to their children. So do have a look at that. It went well. There will be another phase of the campaign, and the results showed that they did actually make some impact. As I say, this is a joint programme with DfE. Nikki Morgan is very strongly committed to improving children's mental health services for children and young people, so there's a lot happening in schools, and I've just picked out some examples. Lots of resources produced on PSHE, for example. I mentioned the schools pilots, and I think they're really important, but they are being rolled out in 26 clinical commissioning groups. The training that was run by the Anna Freud Centre has been delivered, and now what we're looking for is to see whether there is much smoother referral system, whether teachers are actually more confident in those schools about identifying children, young people who actually need referral or who can be dealt with within the school, because our idea and the aim certainly isn't that every child with any kind of problem will be referred to specialist services. We're not just about delivering more of the same. So that's important. There's a DFE counselling strategy, and also whole classroom approaches I think are really important. So I've picked out one developed by the Maudsley, which is called Q's Ed, and I've sat in the classroom with the children who are in year 3 who are participating in this fantastic program, which is about developing resilience, understanding what mental health means, and so on. So there's some fantastic examples of good practice around. Peer support, DFE are putting quite a lot of resource into peer support, and this seems to be quite popular and does need evaluating. But also a lot more therapeutic provision is taking place in schools. So Place to Be, for example, are in 260 schools at the moment, I think 35 secondary schools thereabouts, and a number of primary schools, and in some cases a part of the CYP IUP program, so those staff are being trained and working with local statutory partners and so on. So that's just one example, but there's a lot happening in schools, sometimes using the People Premium to actually commission services such as counselling and so on. And there is guidance on behaviour support, which I think is actually being recommissioned at the moment. So vulnerable groups, well, as I say, one of the task and finish groups was about vulnerable groups, and it looked particularly at the issues of access, but also at things like why vulnerable children don't particularly like to go to CAMS. So what you do about that, because if obviously children are being referred and they're not turning up, then that's not very helpful. It looked at models of care, so that, for example, where you have real expertise locally in things like youth justice or looked after children, that those services can be provided and rolled out on a much broader basis than just providing care on a one-to-one basis, for example. One of the things that we thought we needed was an expert working group to look into what more can be done for looked after children, adopted children and care leavers. As I said earlier, the vulnerable groups report didn't particularly pick out any particular group because it looked very generically and we were trying to keep the report short. But we do recognise that the needs of looked after children and these particular groups are very, very significant and indeed a high profile. So there have been a lot of attention focused on these groups by government. So we are now setting up a group that will be looking into how we can develop care pathways and improve the quality of care and support for those children in those groups. We are also testing personalised budgets for looked after children and care leavers. We've got the first workshop to look into that tomorrow. We're looking for areas who can actually pilot those approaches. I mean, we've tested the concept already. We have proof of concept already, I think, in relation to other groups, but we want to see what more can be done for looked after children and care leavers particularly. We might look at adoption as well, but because of the Adoption Support Fund, that may not be the best way to go. The Adoption Support Fund effectively is already delivering that kind of program for adopted families. So personalised budgets is something to watch. I think it's quite complicated, but we're willing to give it a go and working very closely with DFE on that, and I think that's quite exciting. Some of you will have seen the adoption policy paper published by DFE on the 27th of March, and what that says is that every family will have access to ongoing support and specialist assessment of need. There will also be the development of a health and justice clinical pathway. As you know, there's a lot of work going on there to keep children and young people out of YOIs and formal clinical justice settings, to provide far more support in the community, to invest in liaison and diversion and so on. There is also the recognition in Future in Mind of the need for trauma-focused care, really. So I've given in brackets the example of child sexual abuse and exploitation, but I think it goes much broader than that. I think part of the difficulty that we recognise in the report is that children who've been subject to all kinds of abuse or neglect or witnessing domestic violence and that sort of thing don't always get the recognition that they need. And that actually what's important is that the therapist is sensitive to that and indeed asks about it. So the introduction of routine inquiry and sensitive inquiry is intended to identify adverse childhood experiences So whereby every child, sensitive inquiry should happen for every child. What that basically means is the therapist probing very, very gently to try and identify what might have given rise to the child's mental health problems, if indeed that is the case, or routine inquiries, everybody of age 16 and above, so that's in children age 16 and above and into adulthood. And that was in response to findings of previous research where we found that there were people who'd been in mental health inpatient care, for example, for 20, 30 years, and nobody had ever asked them whether they'd been abused. So clearly this makes a huge, huge difference to the prognosis, to the form of treatment and so on. So putting in place much more sensitive approaches and finding out about adverse childhood experiences, I think, is very, very important. I mentioned children with learning disabilities, and at the moment children with learning disabilities have very poor access to care. So one of the things we're trying to do is to align what we're doing under this programme with Transforming Care, which is obviously aimed at getting children and young people out of formal inpatient settings where they have a learning disability, and that's been very much in the news recently. But there are major complications in doing so, largely around the skills of the workforce and so on, because I think one of the reasons why learning disabled children don't necessarily get very good access to mental health services is because the workforce aren't that well trained on this specifically. So we're developing a number of new curricula under the Children and Young People's IAPT programme. One of those new curricula will be around learning disabilities and autism, and that's due to come on stream fairly soon. There will also be new curricula on eating disorders and 2 or 3 others, so that's obviously a really important development. So just briefly, the other programs that we've got in hand, a workforce strategy starting with a workforce audit, and it's going to be difficult to develop the workforce when we don't know how many people work and children's mental health. So the workforce audit is doing a census to find out how many people are working this across the board. The new mental health data set, as I say, came on stream in January, and that's been 10 years in development. I started that off in 2004 when we published the National Service Framework on Children and Young People and Maternity Services. It's taken a long time to get going, but it is going to be very comprehensive. The data has started to flow centrally now, and we will be getting the first results very soon, although it will take quite a long time, I think, to get the quality up to scratch. The prevalence survey, I mentioned prevalence earlier. We have very poor prevalence data at the moment, so we have commissioned a new survey that will be available in 2018. It's a huge piece of work, and that's been worked on at the moment to find out about all kinds of mental health conditions, including new ones, the impact of cyberbullying, for example, and that should be very useful. Participation, we've recently, NHS England recently issued a specification for participation for the whole programme that will be really good. So the previous CYP IAP programme had a big element of participation, and this wider programme will do so similarly. And I've also already mentioned eating disorders. So that's all I wanted to say. So thank you for listening, but I'm really looking forward to the discussion and answering questions.
Thank you, Claire. That was fantastic. There's a huge amount going on, so it's really, really useful to have an update from and you know, a sense of all of the things that have been going on over the last year or so. So I'm delighted to say that we do have quite a few questions already, and so do keep on sending in your questions as we go through. We've got about 20 minutes for questions now, and so I'll group them where possible, and hopefully I'll get your names right and your questions right, and if I don't, you just let me know through the question pane. Okay, so first of all, so a couple of questions about local transformation plans. Vanessa from the Prince's Trust wanted to know what areas, I guess geographical areas, that the local transformation plans cover, and whether that's by borough. And then the second question about local transformation plans from Cheryl at NCB could you tell us a little bit, Claire, about how the voluntary sector has featured in the first round of local transformation plans?
Yes, certainly, and thank you very much, Emma. So what areas they cover? They were done by CCGs, and they had to be signed off by local health and wellbeing boards, so it's quite a lot collaborated. So I think altogether, I'll see if I've got the figure, but I think there are about 130 produced or something like that. But so some of them came together, but they did have to involve the local authority and other local players. They had to talk to schools and so on. So that was how that was done, but the Health and Wellbeing Board signed them off, and as I say, sometimes on a collaborative basis. And they were also asked to involve the voluntary sector, and some of the analysis will show the extent to which they've done so. So I should have said that on top of the quantitative analysis, which is this particular slide, there's also been a qualitative analysis, which we're just going through at the moment. So although the quantitative analysis has been published already, the qualitative analysis hasn't, because that needs a little bit more work. But that covers things like what we found out from the local transformation plans about crisis care, about vulnerable groups and so on. But there has been also further work done. I think Youth Access actually has done some work to look at the extent to which voluntary organisations thought they'd been involved or felt they'd been involved in the development of the plans, and the answer was variably. So I know, you know, ideally we wanted the voluntary sector in every area to be involved, because clearly, you know, they have a role on many different levels, including services being provided by the voluntary sector, but also, you know, at a macro level in terms of commissioning and contributing to the development of the plan and so on. So I hope that answers those questions.
Thank you, Claire. That's really helpful. And maybe one of the things that we can do, Youth Access is part of the Young People's Health Partnership, so maybe we would be able to share with people some of the outcomes of the survey that Youth Access did. That may be useful. Okay, so we're going to go on to a couple of questions about prevention and early intervention. So first of all, from Lucia at the Nuffield Trust. So she wanted to know what proportion of the efforts that you've been talking about, Claire, go to family-focused early prevention for the youngest children versus increasing service provision to those in immediate need. And so that's including starting in pregnancy. So I guess it's the proportion of resources and focus on very young children and in pregnancy.
Yeah, and clearly that's really important. And one of the 4 Task and Finish Group reports was on prevention and early intervention. As I said earlier, 75 million is going specifically into perinatal mental health. I know that wasn't the question, but I just think that's worth stating. And I mean, we did refer in a couple of places to the role of early years services, for example, but I do feel that probably hasn't had quite the profile that it needs to. So one of the things that we've done now is we've set up a number of Task and Finish groups to look at delivery across the organisations. We have an oversight board, which is the top sort of governance structure that spans all the different organisations who are working together on this. And one of the Task and Finish groups, which has heavy involvement of PHE, is on prevention and early intervention. So they're looking at what more can be done across the age range, really. Pregnancy, I would say, is probably not covered by this. That's not part of this particular strategy, not that it isn't important other than the perinatal stuff, but you know, health promotion during pregnancy and mental health promotion isn't really part of this strategy. But I think the need to focus on early years, particularly in the workforce strategy, for example, I think is absolutely crucial, because we know that people working with those age groups have a major role to play that sometimes isn't recognised. So we need to train staff dealing with children in the early years, you know, to identify problems. It might be problems of learning disabilities, emergent conduct disorder, and so on. And indeed, one of the new curricula that I mentioned is specifically on the early years, because traditionally there have been a lot of services who haven't accepted referrals for children below a certain age, and that varies actually. In some places it's 5, in some places it's 7, and so on. But what we want is services to accept children far more readily at a younger age, as soon as they develop mental health problems, and also to enable the staff who are working with them, health visitors for example, to be able to recognise those issues as they emerge.
Great, thank you, Claire. We've got loads of questions coming in. A couple of people are asking whether the presentation will be shared. You should already have received it, and if you haven't, then we'll make sure it comes out again. But yes, you will be able to get it. Okay, so I'm going to move on. We did have another question about prevention and early intervention, and I guess one of the things is that for the voluntary and community sector who are involved in all levels of delivery, many providers are particularly interested in those issues around early intervention and resilience. And I think the work with Public Health England, it will be really useful to look at in their analysis of local transformation plans how much focus has been on those issues really. But I want to move on to the next question because I just want to cover as many issues as possible. Okay, so this is a question from Gary, and it's about the commitment or the importance of join up with education. And so I will read Gary's question. Claire, you talked about the Secretary of State for Education being committed to supporting the agenda. However, the proposed education white paper, particularly in relation to the testing regime, could be considered to be at odds with that. So what consultation has taken place or could be undertaken to assess the impact of education proposals on children and young people's mental health and well-being?
Yeah, it's a really good question. I mean, it's one that, you know, sort of abuts our program, the transformation program, but isn't directly part of it. But obviously one of the things that we're interested in is children's well-being. So, you know, looking at some of the things that actually contribute to mental health problems, be it, or, you know, it could be bullying, for example, could be exam pressures and so on, because we know from research that our children, young people's well-being in this country is very, very poor. What we don't always understand is exactly why that is. So there is a whole program of work led by DfE on resilience and indeed on what they call character that looks at some of these issues and, you know, as far as there are contributory factors to well-being. I'm afraid I can't go into any detail about exactly what is emerging or likely to emerge from that consultation, because as I say, that goes beyond the department's role, and we'd need to talk to one of my colleagues in DfE on that. But we're certainly conscious of the fact that in terms of research evidence, there is some that shows that you know, things like exam pressure and stress is one of the contributory factors, and that may emerge, of course, in our prevalence study when the results are published in 2018.
Thank you very much, Claire. That's useful. And maybe one of the things that we should also say is that we'll make sure we keep a note of these questions and use it to inform what Young People's Health Partnership and National Children's Bureau are doing on an ongoing basis to contribute to discussions around this agenda. Okay, another question about vulnerable groups. So this is about local authorities having a new duty to support care leavers aged 18 to 21 in a transition role. This duty is not the same for the NHS and is causing some challenges locally. So for example, when it was tried to include proposals within local transformation plans, local NHS England colleagues said that monies had to focus on under 18s. And just wondering, Claire, if you can provide any comment on that.
Yeah, and obviously this is quite difficult because you know, when you talk about children's mental health challenges, transition always comes up, because however bad things are in children's mental health, you know, unfortunately they're very often even worse in adult services. So children who've had significant long and enduring mental health problems such as ADHD, for example, when they get to adulthood, you know, their services sometimes just stop. So, you know, clearly for children in transition there are a huge number of problems. But the money was actually explicitly for children, young people age, you know, 18 and below. However, it's not all about the money, and you know, in fact, the contribution of the money, as I say, 1.4 billion altogether, is just a part of the overall budget. So the budget for mental health is something like £600 million a year, and that's for children, young people, on top of the, you know, whatever's spent on adults. So hopefully further work will be done on improving services for those in transition. So some of the models that we're quite enthusiastic about and are going to do some further piloting on are about improving services for children in transition and looking, for example, at commissioning services for people aged 0 to 25. So Birmingham, for example, last year decided to decommission all their services and recommission services for children aged 0 to 25, which is a very exciting development. They've done the same in Norfolk. And obviously that will have further benefits or specific benefits to care leavers. I think we are going to take care leavers on board in our piloting of personalised budgets, because that is quite exciting. You know, if you gave a young person responsibility and said, well, you know, this is the budget for your mental health needs, but you can do with it what you like. You know, they could be far more imaginative and innovative than, you know, just referring somebody to the usual services that aren't very good. So that's one of the things that we're going to do, but we will be spending more money on piloting going forward. And there may be other things going on within DfE, for example, going forward about care leavers. The government sees care leavers as a very, very high priority. So even though the money wasn't necessarily for that age group, or not for care leavers above the age of 18 anyway, we do think there's an awful lot that will be done. And there is a specification that NHS England published about 18 months ago on transition. So it's not specific to care leavers, but it covers all of those in transition. And it's very, very good looking at what should be available for children and young people as they reach adulthood. And it's all about the planning and the thought that goes into preparation for children. So you shouldn't, you know, suddenly find that somebody's got to the age of 18 and you know, not know what's going to happen to them. So it is all about the planning, and if people were interested in seeing that specification, we could make that available. But clearly care leavers are a real priority, and one of the things that the expert working group I mentioned will be doing is looking at the care pathways specifically for care leavers. So it won't only looked after children in care, it will look at care leavers as well.
Thanks, Claire. So I just wanted to let people know, if you've got a burning question, if you could submit it quickly and make them brief now, because otherwise I don't think we'll cover them all in the next few minutes, because we've got lots of interesting questions to go. So and just to link another question around vulnerable young people elements, this is a question about whether, from Ben Cross, about whether there'll be any requirements to provide access to support for children who are victims of abuse, developmental trauma or attachment difficulties. And this is coming from the fact that it's completely absent in the entire of Berkshire, and a major element missing from provision. But because the numbers affected are relatively low in comparison to ADHD, for example, it struggles to feature when compared to other issues.
Oh, right. Well, I'm not sure I'd agree it was missing, because this was such a big issue in the Task and Finish group. I guess what actually appeared in the report itself, the Future in Mind report, was not that long, but it was set out in far more detail, actually. You know, although I said we didn't really look at individual groups, we did actually look at children who'd experienced trauma and attachment difficulties and so on in quite some detail. So that was why we came up with these recommendations about the different models of care that they need, how to improve access to services for that group and so on. And it's something we're being pressed on within Parliament. The Minister's being asked questions about this on an almost daily basis. And so there's a lot of thinking going on about how you, as I say, how you make the workforce more trauma focused. So, you know, for these children, very often they'll need a different kind of intervention, such as trauma-based CBT, for example, which is different from ordinary CBT, and so on. So I think there is also recognition that these groups, children who've been subject to child sexual exploitation, in general have very poor access. That's not true universally, but in general they don't have very good access to services, and quite often then seen as non-compliant. So if they don't turn up 2 or 3 times, they're just rejected and, you know, ticked off and taken off the book. So, you know, we were very conscious of that and looked in detail at how access might be improved. So, for example, through tackling DNAs in this particular group by offering services online, in non-clinical settings. So one of the examples we gave in the text was of a child who was very, very disturbed following chronic exploitation and abuse, and was dealt with in a very different way by talking to a worker, you know, outside the clinical setting in a car, because that was all she would agree to do. And then eventually she was able to build up a therapeutic relationship with the therapist until she was then able to come into the clinic and have treatment in a more conventional setting. And the ambit approach that was actually talked about in the report, which is specifically an approach based on mentalization. So it was given huge prominence in the report, and indeed mentioned specifically in the guidelines. And in the qualitative analysis on vulnerable groups, we actually set out how many of the local transformation plans actually address the need of this particular group. So, as I say, looking at the links with poor attachment and so on was also thought to be really important, because clearly the evidence on that is really very, very clear.
Thank you, Claire. And I guess one of the things is, if that isn't happening, or you're not seeing that happening locally, I think that's something that's really useful to be fed back to nationally, to your local, your regional NHS office, and to national voluntary sector organisations, because I think that's really useful to see what is actually happening in local areas, given the national priority. Okay, I've got a couple of questions around funding and making economic cases. So Holly has a question about whether there are any tools to run our own local economic cases. So that's a short one, and really important, because we know how important that making the case is. And then there's a second question about funding, and that's that funding is not only welcome but essential, and the challenge is well, because of the national decision not to ring-fence the money, that's causing some difficulties for some CCGs where they have gone back on commitments within their local transformation plans as a result of this. And the question is, how will the Department of Health ensure that the money is spent on children and young people's mental health and hold CCGs to account?
Great. Well, on the local tool, NHS England have developed a tool to help you analyse locally what happens if you spend money on different things. So it's a very, very clever tool that will say, if you invest, say, an extra £100,000 in local, in early intervention, this will be the impact long term, and to actually give you an economic projection. So that's not quite the same thing, but obviously that helps you to build up the local case, and we could send the link to that particular piece of software that will actually help you to do that. So I hope that answers that question. On the decision not to ring fence, I mean, we don't have the ability to ring fence funding anymore, so even though there's been quite a lot of pressure saying that we should do so, that just isn't the way that the system works anymore. So what we have done is to make sure that all the levers that are available are going to be used, and the levers that are available include regulation and inspection, the use of data, so actually publishing data, and there will be things like a dashboard that are published to show how we're making progress and so on. But very, very importantly, the assurance process. So for the previous financial year, 15-16, what we put in place through NHS England was a very robust assurance process to make sure that the money was going to be spent on what people said it was going to be spent on. So the plans, as I say, had to be very transformational. If they just said, well, actually, it's funny that you're going to offer us this new money because we were about to fire 3 of our staff in local government and now we won't have to, we'll just use the money for that. Those plans would have been absolutely rejected. We also had the ability to claw back the money, or the NHS England does. We don't in the Department of Health, that's not what we do. But they will actually monitor quite closely what the money is being spent on and how. So even though the money has gone into local baselines already for clinical commissioning groups, it will be monitored. Now, the system for this year hasn't quite been decided. As I say, it was a very robust system for last year, the first year. The intention was, and what we said publicly, is that the assurance process would just be built into the normal CCG assurance for the current year and subsequently. But that hasn't quite been nailed down yet, and I do think we need something that is reasonably robust to make sure that the money goes on what people said they would spend it on. So, you know, if they said we're going to commit to spending on 5,000 to treat 5,000 more children locally, then that will have to happen. And perhaps it would have been helpful if I'd said that the commitment was that we would treat an extra 70,000 children a year by 2020. Quite difficult when you don't know what the baseline point is, but that was the commitment, and starting quite modestly, 5,000 more children during the current financial year, but by 2020 we hope that will build up to an extra 70,000 children per year.
Thanks, Claire. We've got 3 more questions that I think we can take, and we'll have to have relatively, sorry Claire, it's difficult, isn't it, timekeeping, quite quick answers so we finish on time. But 2 of them are around data and 1 on workforce. So I'll give you the 2 on data. So are there any plans to link the new mental health data set with the Department for Education's data sets of looked after children and children in need? And that's from Dinithi at the University of Bristol. And the other data question was about the prevalence survey, and this is from Cheryl at NCB. So will the new prevalence survey and other data gathering efforts be designed to identify issues for Black and Asian minority ethnic groups?
Right, well, very quickly, although there isn't a direct link, I mean, there's work going on to look at how you can actually link data systems generally, including possible use of the pupil identifier and so on. The minimum data set, the mental health data set, does identify children and young people who are looked after. So the answer to that really is yes. You'll be able to see how many children, for example, have a care plan and so on. And so there will be it's quite a detailed data set. So that hopefully answers that. Yes, the prevalence survey goes into great depth on BME, as indeed the last one that was published in 2004 and the predecessor one in 1999 does. So that will look specifically at BME populations and other groups. So it's a very sophisticated survey based on something like 9,500 interviews that are quite detailed with both teachers, families and children and young people.
And the prevalence survey on identifying Black and Asian minority groups, did you answer that one?
Yes, so yes, indeed.
I was unmuted, sorry. So final question. This is on workforce. So have the Department of Health considered a similar approach to increasing the workforce in CAMS as it did with health visitors?
Yes, and I mean, that was a manifesto commitment by the coalition government, so I don't think we'll be doing that explicitly, but I think what we are doing is looking at how we increase workforce. So starting with the census that I mentioned earlier, we'll then be able to work out, well, how many people do we actually need and at what level, what should the skill next be and so on. So I mean, I'm not sure that we'll have I'm going to say there should be 4,200 new psychotherapists or whatever, but obviously it's part of the strategy is to put the workforce in place by working with both NHS England, perhaps having a return to practice campaign to increase the staffing and so on.
Great, that's brilliant, Claire. Thank you very much. And I guess just on that workforce, I think one of the things that we've talked about at our last workshop was the really important workforce that we have in the voluntary sector, from prevention, early intervention through to specialist provision. And so it's really important that we keep on highlighting that and looking at as a sector how we are involved in transformation as it moves forward. So that's brings us to the end. We're 2 minutes before 3:30, and I just wanted to first of all thank Claire for a fantastic presentation. I think given that there is so much going on in this area, it's really important that we have the opportunity every now and again to catch up, and so that people can be really informed and then be really engaged as we move forward. So I would really encourage you all to continue to engage both in your local areas with your local transformation plans as they move forward, but also with feeding in things to us, those voluntary sector organisations working at a national level. And certainly I know that NCB and the Young People's Health Partnership are always really keen to hear from you about what's going on in your area and the impact that all these positive changes are having, hopefully, for children and young people. So before we leave, I just wanted to let you know that once you leave today's webinar, you will receive a follow-up email with a link to view a recording of today's webinar. And we would also really appreciate your feedback and comments about today's event. But that's it. Thank you so much on behalf of NCB. Thank you to NCB for hosting, but also on behalf of the Young People's Health Partnership and our presenter Claire. Thank you for joining us today and have a good rest of the day. Bye-bye.